Again, I would like to welcome Dr. Loevner for her next talk about blind spot in head and neck. Thank you very much.
We have an arrow. Perfect. All right. Good morning again. Great to see you. This is one of my favorite subjects. I'm a person that loves talking about missed cases. I mean, missed cases are the most important educational tool that we have. So I'm going to be talking about blind spots in head and neck imaging today. So the learning objectives of this talk are we're going to review perceptual errors, we're going to closely study interpretive errors, and we're going to evaluate causes for the errors and identify strategies to reduce them. And we are going to do this by illustratively reviewing a series of missed cases. So every single image I'm going to show you here was either a missed finding or a finding that was found, but its interpretation of the finding was incorrect. So a blind spot is an area in your range of vision that you cannot properly see with your retina, but that you really should be able to see. We are all familiar with this when we're driving, right? We have rear view mirrors and side mirrors, but there's that certain portion lateral to your car where your retina doesn't pick up the car in the side lane. Same thing happens with fighter pilots, and fortunately for artificial intelligence, we now all have adaptive mirrors that let us see that car in the blind spot, and many cars now beep for you when there's a car in your blind spot. And the same thing on country roads. We have a lot of adaptive mirrors here to show us structures in our blind spot that we can't routinely see. A perceptual error is an abnormality that is retrospectively identified that was not seen at the time of initial film interpretation, and that's what we mean by a blind spot. It's a perceptual error, something we should have seen, but we didn't. So let's look at a bunch of them. This is a missed necrotic retropharyngeal lymph node metastasis. This is a missed necrotic level 3 necrotic lymph node metastasis. This is a small Delphian lymph node that was missed in the setting of laryngeal cancer. This is a missed lymph node along the external jugular chain in the setting of metastatic skin cancer. This was a missed mucoepidermoid of the parotid gland, relatively dark on T2 weighted imaging. This is missed brainstem and cerebellar metastases, pretty big findings. This is a missed horseshoe carcinoma of the supraglottic larynx. This is a missed soft palate tumor. This is a missed tumor in the apex of the piriform sinus. This was missed lung metastases. This was a missed peripheral nerve sheath tumor, and what happened 2 months later, this is what their malignant peripheral nerve sheath tumor. So these are all perceptual errors, things that should have been seen that weren't. So what causes perceptual errors? So reader fatigue. I mean, we're tired, we're reading high volumes, and I would say in my practice, the most common thing is distractors. The phones are constantly reading, our emails are constantly going off, we're getting consults by telephone, and very, very high volumes. All of us are experiencing the high volumes as really radiology in many ways has replaced large portions of the physical examination. I think another problem, especially with young people that are getting out, they miss that satisfaction of their search. They see a finding, they're so fixated on it, they forget to look at the rest of the film. Suboptimal image quality, so you have to have good imaging, or doing the wrong imaging test. Sometimes you really need an MRI, not a CT scan. Sometimes you need a CT and not the plain film, etc. And then clinical history. Clinical history is important. If you have insufficient history, it may lead you down the wrong tree, or in fact, if you are misguided by incorrect history, that too can lead you down the wrong tree. So those are perceptual errors. Cognitive errors, those are interpretive errors. These are findings that are detected, but the meaning of that finding and its significance isn't necessarily recognized or understood by the person interpreting the study. This is what we call blind knowledge, okay? A blind spot, something you miss that you should see. This is something you see that you misinterpret. And very importantly, these interpretive errors are frequently accompanied by perceptual errors. So you make the finding, you misinterpret it, and then you miss ancillary findings on the film that perhaps would have had you come to the right diagnosis of the major finding you were looking at. And honestly, a lot of these are just in your face. They're just very, very big errors. We all have them. Nobody practicing doesn't have errors. That's why we call these learning opportunities. So let's look at a bunch of missed findings here. This is a finding where you'll see these necrotic areas. These were read as metastatic lymph nodes, but this is actually jugular vein thrombosis and a clot in a facial vein. This is somebody that was read as having parotiditis in the setting of facial swelling. This is actually anaphylaxis to contrast. This is somebody that has a fish bone that is retained in their aerodigestive tract. Here is this scan here showing you this. This was read as ossification of the stylohyoid ligament. The fish bone was missed. This is somebody that had a perineural spread. This was interpreted as a vein, okay? This is somebody with a clival mass. It was interpreted as metastasis. It's fibrous dysplasia. And this is somebody, you'll see a very demarcated lesion in the tongue. This was read as a tongue-based mass, but this is denervation of the tongue. And the perceptual error that occurred with this cognitive error was the metastasis to the occipital condyle. You see the normal fat on the opposite side. And this has gone into the hypoglossal canal and paralyzed the tongue. So that is the perceptual error with the cognitive error. Okay, causes of cognitive errors, lack of knowledge and lack of subspecialization. There are just certain areas where you really need to have subspecialty training, and that's why it's so wonderful to see everybody here trying to get into the depths of head and neck imaging, so it's wonderful, to share this with you all. Insufficient clinical history. This is really where you need clinical history, and especially in cancer patients. You cannot read cancer patients, no matter how good you are. You have to have the appropriate management history, presentation history, as well as other areas of systemic involvement. You can be misguided by inaccurate or incorrect clinical history, failure to use prior imaging. This is a big pet peeve of mine. You must look at the prior imaging. If there's a neck CT, you should be looking at the PET. You should be looking at the baseline presentation study if you're looking at a follow-up. This is another pet peeve of mine, people propagating errors on prior imaging reports. So they see it, the report says it is, and therefore it must be. But just because it was there doesn't mean that it was correct, and I always tell people, look at the old imaging, come up with your own idea, then go back and look at the report and see if they match. But don't just propagate something and assume that everything you're reading in a prior report is correct when it may not be. Again, fixation on a specific diagnosis or findings such that you miss the ancillary findings and you don't understand what you're looking at, and poor communication. Unclear reports, those don't help, okay? You have to communicate with your referring clinical colleagues, and when in doubt, the patient and the radiologist. I pick up the phone and call the patient frequently for outside patients when I don't know what's going on with them. So blind spots and blind knowledge. So these are symptoms that should make each of you very nervous. Facial pain, I don't care. Facial pain scares me. When I get facial pain, I am looking at every skull-base foramina, Dysphagia, ear pain, usually referred from oropharyngeal lesions, piriform sinus lesions, dysarthria. Okay, that scares me. When somebody tells me they feel a bug crawling on their face, I know they have perineural spread. And headaches. Now, headaches are very common. Don't forget to look at your skull base, the bones in your skull base, the tissues around your skull base. A lot of those things present with pathology. And when you have these symptoms, think of the priceless real estate that you should go back and check. Look at your aerodigestive tract for emergencies or for an occult cancer. Look at your skull base foramina for perineural spread or patterns of denervation. You heard yesterday, every time you look at a cranial nerve, don't just look at the nerve, you've got to follow it to its end organ. Is the end organ atrophied? Okay, that'll help you a lot. And please don't forget to look at the bones. I see so many bone misinterpretations. So here's that 52-year-old with throat pain and coughing after swallowing a chicken bone. So this was read as an aspirated chicken bone. This is not an aspirated chicken bone. It was actually referred to as a wishbone in the report. If you look very closely, this is just a heavily ossified thyroid cartilage. And when in doubt, check it out. First of all, when you're looking for foreign bodies, you should do unenhanced imaging because the contrast can make it difficult to pick up a small foreign body like a fishbone. Also, when you're getting ready to read a foreign body, think about normal structures, the cartilages, the hyoid bone, the stylohyoid ligament, and when in doubt, again, if you have a plain film, which is really the quite correct way to start the workup of a foreign body, get an unenhanced CT. Here's a 44-year-old with a sore throat and it was drooling after eating. This is how it happened. They got a plain film and this was read as normal. Then the attending came in the next morning and got the additional history of eating sea bass. And you'll see here that there's a lesion, right, sitting here coming down. Well, this was read as the ossified stylohyoid ligament, the styloid process, just telling you how it rolls. And if you can't believe that, here's the axial images. You'll see this calcification in the submucosal region of the pharynx coming all the way down to the pharyngoepiglottic junction here. This was also read as an ossified stylohyoid ligament. We all know that this is the fish bone that the patient aspirated, but again, an interpretive error. People got fixed on an idea and missed the diagnosis. This was a very hard foreign body to get out, which was a whole separate set of errors by the surgeon, but this is how it happens. So it is important. I see this happen about 3 times a year where the stylohyoid ligament is interpreted instead of the retained foreign body. This is the mastoid process, the styloid process. The stylohyoid ligament runs between the internal and external carotid artery to insert on the lesser cornua of the hyoid bone. And this may ossify or calcify. It's important to recognize that it goes to the anterior third of the hyoid bone. If you look at this here, this is an ossified stylohyoid ligament. You can see it here, a very nice stylohyoid ligament, and it comes down towards the anterior portion of the hyoid bone. In contrast to our patient that has a retained sea bass fish bone, where you can see that this is inserting or projecting over the back third of the hyoid bone, so you should know that it's not the stylohyoid ligament. This is another person that was eating sea bass and had a retained fish bone in the lingual tonsil. This was also missed on the plain film, then it was missed on the contrast-enhanced CT, and I think that's the teaching point of this case. Wrong technique. When you're looking for a small foreign, radiopaque foreign body, please do not give contrast. It just makes it, this would have been much easier to see if it weren't embedded in the enhancing lymphoid tissue sitting in the vallecula from the base of the tongue, but this was the sea bass bone that actually got taken out. And this is a mass in the piriform sinus that was read as a tumor. If you look very closely, it's very circumscribed, and here you'll actually see some air sitting inside of it. So this is a peppermint candy. It's a retained foreign body in the piriform sinus that was read as a tumor, and peppermint candies are very porous, so they get air in them. Just a little pearl. You can distinguish it from a butterscotch. This is a different patient, and this was read as a piriform sinus tumor. So here you'll see some air in an extraordinary location. Not all of it is in the piriform sinus. And I will say that you see a lot of enhancement of the mucosa in the piriform sinus, and you do see a lot of swelling. So I can see how it was read as a tumor, but if you look very closely, here's a radiopaque foreign body, a radiopaque foreign body, and a radiopaque foreign body. I picked up the phone, I called the patient. He said, "Oh, Dr. Loevner, I was giving myself insulin and I aspirated my needle a few weeks ago, and I thought I swallowed." This was an aspirated insulin needle. And here you can see the coronal view showing you the lesion. He was elated because he went from having cancer to an inflammatory reaction around a foreign body. That was also very difficult to get out. This is just to remind you, this was read as a needle. This is just the face mask in the era of COVID, so remember the face masks that are there. This is a missed esophageal perforation. So somebody else that ate a fish bone, and here you see the pneumatosis sitting inside the wall of the esophagus, and here you'll see air in the mediastinum around the azygous veins, right? So again, things that you want to think about. This is that 25-year-old male with fever and respiratory distress. This is the clot in the internal jugular vein that was interpreted as necrotic nodes. These were pulmonary emboli that were interpreted as pneumonia. And you'll see here the cavitary opacities. These are septic emboli, and this was venous thrombosis. And if you had gone back and got a history from the patient, 3 weeks earlier, they were in our ER with really bad tonsillitis. You can see the enlarged tonsils with fluid and air in the crypts. You can see the reactive lymphadenopathy, and this is Lemire syndrome. So that's thrombophlebitis in the internal jugular vein with metastatic sepsis. The lung is most common, but you can get emboli to any organ. And these are most often preceded by an oropharyngeal infection that may be a peritonsillar abscess and or a retropharyngeal abscess. Again, this is a situation where history would have helped the clinicians come up with the right diagnosis. There is a male predominance, and they say it's, 16 to 25-year-olds. There was 1 week where we had 3 of these, and they were all between the ages of 40 and 62. It spares no age group, and it spares no sex, and it's normally from gram-negative bacillus in 80% of the patients. Here's just another Lemire syndrome, a retropharyngeal effusion, clot in the internal jugular vein. Here again is the retropharyngeal effusion, and here you'll have the septic emboli in the lung. So the take-home points for Lemire's, because I think this is important, this is a radiologic diagnosis. Don't want to read it as an isolated oropharyngeal infection. You don't want to read it as isolated internal jugular vein thrombosis or adenitis or pneumonia, even METs. You want to put all the findings together, right? Get all the findings together in the context of the history. You should have a high index of clinical suspicion. It's a radiologic diagnosis. And if you wait for cultures, it may be too late. It can be very pathologic. This was a patient that came in with a sore throat and was read as having pharyngitis. We all know anatomic misstep. This is the epiglottis. This is actually epiglottitis, and it was strep pneumonia. You can see the classic thumbprint sign on the scalp topogram. Epiglottitis happens in adults. It can be it's the same symptoms as pharyngitis, as in this case. In adults, you want to think about infection, but you also want to think about chemical, thermal injuries, hot foods, allergic reactions, and trauma. So I would say once a month we see a very bad case of epiglottitis that's due to intubation. So we see a lot of, there's a lot of intubated patients in the field, and it's not uncommon to see this. The management, don't manipulate the airway, let somebody else deal with it, and you want to treat the underlying cause. This is swelling of the aryepiglottic fold from a nifedipine allergy that was misinterpreted as a tumor. Just so you know, you got to get the history. And here's that 24-year-old outpatient that was being imaged for neck masses and bilateral facial swelling that was read as parotiditis. This is massive enlargement of the glands. You can see all the reticulation in the fat. The glands are enlarged. Here's swelling of the epiglottis, retropharyngeal edema, swelling of the epiglottis, retropharyngeal edema, and this is anaphylaxis to IV contrast. Definitely something you don't want to miss. Now, moving on to interpretive errors and perceptual errors in the setting of cancer, so important. This was a study that I did, 2 decades ago, but I still use it every day. We reinterpreted cross-sectional imaging studies in the setting of a multidisciplinary cancer center. So we had 136 patients come in. Their outside films were reinterpreted by me in the context of the clinical history. A report was generated, and then we went back and compared my report with the outside report, the clinical finding. All the findings were either confirmed pathologically in 75%, 18% with characteristic imaging findings, and 7% with clinical or imaging follow-up. And what we found was that 56 to 130 of the 136, or 41% of the patients, had a change in interpretation, a complete change in their 41%, due to perceptual or cognitive errors. The vast majority of these really were due to a lack of understanding of the disease they were looking at or a lack of the appropriate history. And in 34% of these 46 patients, there was a change in T&M staging. In 95%, the change in radiologic interpretation either changed treatment or the prognosis of the patient. So this is very important and gets back to the concept of reading films, being subspecialized, understanding the diseases that you're looking at, and using clinical context and communication with your clinical colleagues. So here's a 54-year-old woman that had headaches and facial pain. This was the initial read. It was read as normal. Okay, it's not normal. There's something in the cavernous sinus, there's something in foramen rotundum, and there's something in foramen ovale. It was read as normal, headaches and facial pain. Well, what if I gave you the additional history of a 54-year-old woman with weeks of facial pain and numbness, forehead weakness, right, seventh nerve, ptosis of their eye. And I also told you that 1.5 to 2 years earlier, they had a lesion on their left eyebrow. You might be thinking of something different, right? So if you look here on this patient's axial images, these are the superior ophthalmic veins. This is perineural tracking on V1, right? The eyebrow on the left has a lesion on it. A few years later, we've got perineural tracking on T1. It comes through the superior orbital fissure. It goes to the cavernous sinus, right? It comes down to foramen rotundum, down to the pterygopalatine fossa. Now you're going to get retrograde perineural on V2, and you'll see the tumor sitting in foramen ovale. And remember what I said, right? The motor branch for the muscles of mastication comes off of V3 underneath the skull base. And if they were astute, you would have also seen the denervation of the left muscles of mastication. So here you'll see the coronal image, perineural tracking on V1, taking you back through the superior orbital fissure to the cavernous sinus, and then you'll see tumor in foramen rotundum, and this is perineural tumor spread. It most commonly affects cranial nerves 5 and 7, primary locations. You don't just stop, oh, I see perineural spread. You gotta find the primary. You wanna look at the skin, you want to look at the nasopharynx, and you want to look at the paranasal sinuses. This was a patient with jaw pain that was read as normal. There's a mass in the eye, and if you look closely, there's a mass in the pterygopalatine fossa, a mass in foramen rotundum, a mass in the inferior orbital fissure. Okay, so now we have perineural spread to the eye. How did it get there? This is the small occult nasopharyngeal cancer with perineural spread. So again, put your phones down, look, find the primary, very, very important. This is nasopharyngeal cancer. This is an inverted papilloma that was read as a mucocele. It doesn't look like a mucocele, the bone's destroyed. And what happened was this was all nicely surgically resected, and 9 months later, the patient came back with a 6-nerve palsy. So what happened? If you look on the T1 weighted image here, you'll see there's a mass in the cavernous sinus. That mass is causing their 6-nerve palsy. What was missed? 3 months postoperatively when they had their routine scan, this is perineural spread along V1. So again, very important. You have to know the diseases you're looking at. Yeah, this is right near where the supraorbital foramen is, and you have to have a concept of what you're going to be looking for, if the understanding of the disease that you're looking at before you actually look at the films. Here's perineural spread of V1 in a different patient that was missed. This is adenoid cystic carcinoma, perineural spread on V1, all the way back here. Didn't quite make it, fortunately, to the cavernous sinus. This was a patient that came in with hoarseness. So remember, you have to follow the vagus nerve and the recurrent laryngeal nerve all the way through their chorus. The recurrent laryngeal nerve on the left goes in the aortic pulmonary window underneath the aortic arch. This wasn't mentioned. They're busy looking at the neck, so there's a missed mass in the aortic pulmonary window. This is vocal cord paralysis, right? The mass is compressing the recurrent laryngeal nerve. You see the dilatation of the laryngeal ventricle and the medialization of the arytenoid. Here on the PET, you now see the FDG avid mass, and very, very importantly, you want to make sure this is compensatory uptake. in the contralateral vocal cord. This isn't pathology, this is physiologic uptake in the right cord because the left cord is paralyzed. And this is small cell carcinoma compressing the recurrent laryngeal nerve and causing vocal cord paralysis. This was a patient with ear pain that was read as having mastoiditis. You'll see some enhancement here in the mastoid, but if you're astute, you'll see that there's something in the middle ear cavity, and you'll see that the vein here is enlarged. If you're really astute, you'll see that this is a mass in the vein. This is the normal side with flavoids in it, right? And if you got the additional history, the patient had dysarthria and dysphagia, right? So you want to be looking at your cranial nerves, and this turned out to be a paraganglioma in the jugular foramen that was misinterpreted as mastoiditis. This was a 29-year-old that came in with quote-unquote a tongue mass and dysarthria. The initial diagnosis in this 29-year-old was a base of tongue cancer. I mean, I can share with you that there's no mass here. I just see the tongue protruding back. And so if you got the additional history that 2 weeks earlier they were hospitalized for asthma and prolonged coughing, you would go back here and see that this is tongue paralysis, not a tongue mass. And here you see marked dilatation of the internal carotid artery and an absent flavoid in the contralateral internal carotid artery. And this is that patient we looked at earlier, coughing, violent coughing, bilateral carotid artery dissections at the neck. And here you see the pseudoaneurysm on the right. And on the left side, you see the high-grade stenosis, the pseudoaneurysm here, and mural clot around these bilateral dissections. This is a 63-year-old, clinical diagnosis, angioedema in the ER. They had been started on a new cardiovascular medicine. You can see then this was read as a base of tongue cancer, but if you're astute, you'll see this very geographic appearance, the bulging of the base of the tongue, and this is tongue denervation. Okay, so reinterpretation, tongue denervation. It wasn't angioedema, it was a swollen tongue from acute denervation, and that's what happens. It swells in the acute setting. You're not done. Oh, tongue denervation, you got to find out why it's denervated. This was the perceptual air that was missed. Here's the other finding. You see the metastasis to the occipital condyle and perineural spread into the hypoglossal canal, causing the tongue paralysis. This was metastatic prostate cancer. Here's a missed occipital condyle metastasis, normal side for comparison. This is a mass in the clivus that enhances. This was fibrous dysplasia. You know, the air here. Anytime I see a bone lesion to skull base, I get a corresponding CT. This is classic fibrous dysplasia. This patient was scheduled for the operating room to take out this meningioma. This is another case of fibrous dysplasia. Got to do, the complementary imaging studies. And this was read as a meningioma, an intraosseous meningioma. Might be a good choice in a 60-year-old, but in a 19-year-old, you should be thinking about something else. This is hair-on-end periosteal reaction, and this was a Ewing sarcoma. So take-home points to air is human. Strategies to reduce errors. You've got to have an organized pattern of film reading. You've got to have your own personal checklist. Each of us has our own little areas we just don't see well. Mine's the supraclavicular fossa. There's never a case I don't go back and double and triple check. It's a very busy area with arteries and veins. You've got to go back and look. My area is the supraclavicular. You have your areas. Know them and go back and double check them. Get an accurate history. Avoid fixation. When you see that finding on the film, don't go, oh, woo. You've got to look at the rest of the film, right? To have that satisfaction of searching it. Review prior reports and imaging, but don't look at the reports until you've looked at the images in context with yours so that you don't propagate an error in a prior report. And I always say, if you're distracted, if I get a phone call, in the middle of a case, I'll take it, but I reread that film from the beginning when I go back to it. Don't just try to pick up where you left off. And if you're tired, save it for later or tomorrow. The last person of the day deserves the same care as the first person of the day. Very, very important. To err is human. Artificial intelligence, I think the role here is utilization and prioritization. Have good communication, give concise reports, talk to your doctors, and if necessary, pick up the phone and call the patient so that you have an accurate clinical context. Have quality and safety committees so that you can review and track errors. There might be system errors in your system, an imaging error. And when in doubt, check it out. Consult your partners and consult the subspecialist that you work with, somebody that might have more experience. Thank you so kindly for your attention, and we are right on time. Thank you. So we're going to go back and we're going to finish up the cartilages, which are so important in this here. Let's just go to where we where we finished. All right, so remember, we said cartilage invasion impacts treatment. We're back on laryngeal cancer now. It really affects treatment selection. It also has indications for local control and overall survival. We're going to look at the development of the thyroid cartilage, and then we're going to look at CT and MRI for anatomic variations, and we're going to look at the limitations of imaging. So major cartilage invasion means the patient is going to have a laryngectomy. Chemotherapy is contraindicated because you may get necrosis of the cartilage. Here's an example of early necrosis, air in soft tissues where it doesn't belong. This is radiation necrosis. And you have decreased local control and inferior survival rates if you treat a tumor with cartilage invasion, major cartilage invasion, with radiation when surgery is the appropriate management. Minor cartilage invasion, which is just erosion of the inner cortex, can be treated with chemoradiation. Local control is not affected, and there's no significant difference in survival rates as long as the larynx is functional. So let's look at thyroid cartilage mineralization. Ossification of your thyroid cartilage begins in the posterior inferior lamina, and it proceeds anteriorly and superiorly, and it ossifies later, often well into your 60s. Many of us sitting in the audience, we're still ossifying our thyroid cartilage. Here's an example of a thyroid cartilage from inferior to superior in a 40-year-old. You'll see the ossification of the posterior and inferior thyroid cartilage. As we move cephalad, we'll see that the anterior portion of the thyroid cartilage is not completely ossified. This is ossification or sclerosis of the arytenoid. That's an anatomic variant, and it's more often on the left. Normal adult thyroid cartilage. So here you'll see non-ossified cartilage anteriorly, right? This is it. And then you'll have the ossified cartilage that has the cortical margins. Most often you're going to see a lot of fat in the medullary cavity. And it's also important to remember at the attachment of the vocal cords, there's a lot of increased tension on the cartilages there where they insert, such that the cartilage is replaced by bone where the anterior commissure is, and that is what you're seeing here, this dense mineralization. Variations in cartilage calcification. So here's patient 1. You'll see here that their cartilage looks like, and here they're pretty densely calcified. This is a different patient, much more bulbous appearance of their cartilage, more fat in their cartilage as you come through here. Very, very different patterns of. Here's patient number 3. Here's a different pattern. This person is very smooth, and if you look here, everything is ossified very early in them. And patient number 4, where there's not a lot of medullary fat, this person's got a lot of sclerosis in their medullary cavity. Now, variations in cartilage mineralization are very, very common, but left to right symmetry, it should be present in 90% of patients, which is going to help you when you're looking for cartilage invasion, right? You're going to go to the opposite side and say, does it look the same? And so here's 6 different patients, and you can see this symmetry in the appearance of their cartilages, right? Another patient symmetric cartilage, another patient symmetric cartilage, and another patient. Marked symmetry from left to right, and that is going to help you when you're looking for cartilage invasion. In the 5 to 10% of patients that don't have symmetric cartilages, you'll frequently see foci of mineralization within non-ossified cartilage, as you do in these patients. Here's another patient. Or you might find focal fat within ossified or non-ossified cartilage. So these are some of the things that cause asymmetry. Major cartilage invasion should have lysis of the cortices, marrow involvement, and often spread into the extralaryngeal compartment. You want to look at the strap muscles. Here is your thickening of the strap muscle here. You can see the difference, right, in the cartilage. This one's missing cortex and marrow. And if you look at this person, you can see that there's erosion of the cartilage, but there's abnormal soft tissue in the thyroid cartilage, and there's swelling of the overlying strap muscles. And this is an example of minor cartilage invasion. Here you can sort of see the cortices. Here on this side with the right true vocal cord cancer, there was minor cartilage invasion at surgery, very hard to pick up. I think that's the bane of the existence here when it comes to thyroid. Here's another example of thyroid cartilage. This is just minor invasion where the inner cortex is missing. And this was also confirmed at surgery. Here's patterns of major cartilage invasion. This is important because this is T4 disease and requires a laryngectomy. Here you'll see marked involvement of the inner cortices, the outer cortices, the marrow. And a different patient, this tumor has actually grown through the sternal notch into the soft tissues and is eroding the thyroid cartilage from the outside. And here's a different patient where you can see the through and through in cartilage invasion and the thickening of the strap muscles. Here's a piriform sinus cancer, right, growing behind the cornua of the cartilage. And these are examples of extralaryngeal extension through and through the cricoid cartilage into the soft tissues, through the notch of the thyroid cartilage into the soft tissues. And this is an example of it going through the thyroid cartilage, again, into the soft tissues. Transglottic spread, cartilage invasion here, very easy to see. And don't forget to look at your strap muscles, very, very important indicator. And again, this is the fixed arytenoid and the invasion also here, destruction of the medullary cavity and cortices of the cricoid cartilage. On MRI, you want to see on T1 weighted imaging, hyperintense fat, look at the symmetry. On T2 weighted imaging, high signal intensity, similar to fat. And on fat suppressed enhanced imaging, nice suppressed marrow. That's what normal looks like. Here's a different patient, different pattern of mineralization, but looked at the marked symmetry of their thing here and nice post-contrast images showing the suppressed fat in the marrow. So when you have cartilage invasion on MRI, T1 weighted, the marrow should be hypointense if you have invasion. On not fat sat, the marrow is hypointense relative to normal fat. And on fat suppressed imaging, the marrow is hyperintense. These are the findings of cartilage invasion. Minerva Becker, I have a lot of respect for, did a study and said, well, you know, if the enhancement of the cartilage is brighter than the tumor, or the hyperintensity of the tumor is brighter than the tumor, then maybe you've got inflammation. This is 75% specific. It's really not different than just using these three findings here. So you're looking for hypointense marrow, and on T1, hypointense marrow, if you're looking at a non-fat CT2, you're looking for hyperintense marrow following contrast and fat suppression. Again, here's a normal cartilage in patient 1. Here's a different patient, nice normal cartilage in this right vocal cord cancer, but you can see that the cartilage is normal, the marrow it doesn't enhance, compared to this patient where the whole thyroid cartilage is replaced, all the fat is gone, normal side. Here's their contrast enhanced imaging, enhancing cartilage. This is the normal suppressed fat on the normal side. Left thyroid cartilage invasion, here's the normal thyroid cartilage, here's the cartilage replaced by tumor. Normal suppressed cartilage following contrast, enhancement of the cartilage, similar to tumor, that's cartilage invasion here. So take-home points, there are extreme variations in cartilage mineralization. You should be looking for left to right symmetry when you're looking for cartilage invasion. Invasion and non-ossified cartilage is very difficult. Imaging is not sensitive for minor cartilage invasion. I think that's major we can make, and that you want to make that finding. Minors is very difficult, but I don't sweat it too much. If the larynx is functional and there's an acceptable tumor volume as determined by our clinical colleagues, they're likely still a great candidate for organ-preserving chemoradiation. And don't forget, you can get false positives on MRI due to inflammation. Thank you very much, and thank you for allowing me to finish. Okay.